Hello students, I am Əliyeva, an associated professor of Pathophysiology department, and the lecture will be delivered by me today. The topic of lecture is Pathophysiology of blood circulation. Circulatory insufficiency is a state when the cardiovascular system cannot provide organs and tissues with blood in an amount corresponding to their metabolic needs, and there is a complicated classification of it. According to the origin, there are cardiac, vascular, and mixed forms. According to the level of the compensation, compensated form and decompensated forms are known. In the compensated form, the signs develop only during physical exertion. And in decompensated forms, all signs of the circulatory insufficiency observed appear even at rest. And according to the cause, acute and chronic forms are known. For example, in myocardial infarction, paroxysmal tachycardia, cardiogenic shock, the acute circulatory insufficiency develop. And for example, in cardiosclerosis, cardiodystrophy, heart defects, the chronic form of the cardiovascular insufficiency develop. According to the manifestation, 3 degrees of the circulatory failure are distinguished. At first degree, signs of circulatory insufficiency, that is the decreased contractility of the heart, dyspnea, tachycardia, fatigue, all these signs are manifested during physical exertion, not at rest. At the second degree, signs are manifested even at rest. And the third degree, in this degree, besides the signs of circulatory insufficiency, dystrophic and destructive changes are observed in all organs and tissues. The manifestation of the circulatory insufficiency. The first sign is the tachycardia. Tachycardia develops by Bain-Bridge reflex. This reflex appears during decreasing of the pressure in the aorta and carotid sinus, and also increasing of the pressure in vena cava and pulmonary veins. Mechanoreceptors are irritated here, and impulses through the afferent fibers transmit to the sympathetic nucleus of the medulla oblongata. Sympathetic innervation of the heart stimulates, and reflex tachycardia occurs. Despite the fact this reflex is aimed at increasing of cardiac output, the protracted tachycardia limits the compensatory capability of the heart. The next is dyspnea. Dyspnea develops by these ways. Acidosis develops as a result of circulatory hypoxia, and increasing of the hydrogen ions irritates chemoreceptors on the wall of the vessels and the receptors on the respiratory center. On the other hand, the hypercapnia increases the excitability of the respiratory center. The next is cyanosis. Cyanosis occurs as a result of the weakening of the blood flow in the tissue, and the oxygen consumption is accelerated, and the content of carbon dioxide and the reduced form of the hemoglobin increase in the blood. Edema. The main sign of the circulatory insufficiency. In right ventricular failure, fluid accumulates in the lower parts of the body, and in the left ventricular failure, pulmonary edema develops. Cardiac cirrhosis is a characteristic for right ventricular failure. It's manifested by functional disorders of the liver and portal hypertension. And polycythemic hypervolemia. Circulatory hypoxia compensatory leads to the acceleration of the hematopoiesis and an increase in the circulated volume of the blood. And at last, nicturia. Nicturia, the prevalence of the nocturnal diuresis over daytime. At night, when the patient takes a horizontal position, the volume of the blood entering the heart increases, and this increases the secretion of the natriuretic hormone. This hormone accelerates the excretion of the sodium and water from the body. All hemodynamic indices parameters change during circulatory insufficiency. The first is stroke volume and cardiac output. The amount of the blood pumped by the heart for each systole into the aorta and pulmonary artery is called the stroke volume or systolic volume of the heart. It's about 70 milliliters in north. and the amount of the blood pumped from the ventricle in a minute is called cardiac output or minute volume. To determine the minute volume of the heart, the stroke volume of the heart is multiplied by the number of the heart contractions, heartbeats per minute. And systolic volume, a very important index, and systolic volume means volume of the blood remaining in the ventricles after systole. And the end diastolic volume is the amount of the blood that accumulates in the ventricles during the diastolar period. The next is ejection fractions. To determine the ejection fractions, the end systolic volume is subtracted from the end diastolic volume, and the result then is divided into the end diastolic volume. Normally, in the left ventricle, ejection fraction is 55-75%. And this index decreases in the heart failure, in the circulatory insufficiency. The cardiac index decreases in the cardiovascular insufficiency. Normally, the oxygen utilization index is 0.3-0.4. This means the tissues absorb 30-40% of the arterial oxygen. And in circulatory failure, due to decreased blood flow rate, increase the percent of the oxygen utilization. It's also considered as a compensatory mechanism. The volume of the circulating blood increases too. The systolic arterial pressure is 100-130 millimeter hydrogen mercury, and diastolic is 60-90. And the central venous pressure, this pressure in the vena cava superior or right ventricle is 12-15 millimeter of the saline, and the peripheral venous pressure is 6-12. Cardiac insufficiency or the heart failure. This means disturbance of heart to push out blood in the peripheral vessels in an amount that doesn't meet the needs of the body. At the same time, the heart cannot push out all the blood into the arterial system entering through the veins. Myocardial pump, the increasing of the heart work, pericardial and mixed types of the heart failure are distinguished. In myocardial pump, damage initially occurs in the myocardium itself. This change may be associated with the damage to cardiomyocytes, for example in ischemic heart diseases, or pathology of the cardiac conduction system, for example in arrhythmias. In the pathogenesis of the heart failure associated with increasing of the heart work, heart overload, two mechanisms should be noted. The first is the overload of the heart when an excess volume of blood occurs when it enters the heart and its chambers more than normal. And such heart overload is observed mainly during increasing of the blood volume, as well as in valve insufficiency. In case of insufficiency of aortic and mitral valves, and the left ventricle is overloaded. In case of insufficiency of the pulmonary valve and tricuspid valve, the right ventricle is overloaded. Heart overload due to increased resistance occur when the heart must overcome the increased resistance exerted by the expulsion of blood. Such an overload is observed against the high blood pressure and narrowing of the heart orifices. Pericardial heart failure is observed in the pericarditis, and mixed type heart failure develops with various combinations of the above mentioned factors. Besides of this, the left ventricular, right ventricular failure and total heart failure are distinguished. Left ventricular failure can be caused by damage to the left ventricle, for example in mitral valve diseases, during cardiosclerosis, and in acute increase in the resistance to blood flow in the arterial hypertension. In this case, congestion occurs in the pulmonary circulation, and acute left ventricular failure manifests itself in the form of the cardiac asthma and pulmonary edema. In these patients with chronic left ventricular failure, persistent dyspnea and cough are observed. The cause of the right ventricular failure can be pulmonary embolism, emphysema, pneumosclerosis, and etc. In such cases, due to the fact that the work of the right ventricle increases sharply, its contractility decreases, and venous congestion is formed in the veins of the greater circulation. The volume of the liver increases, and the edema is observed in the body. The chronic right ventricular failure, this change develops slowly, skin temperature decreases, and cyanosis is observed. Venous congestion in the liver leads to the hepatomegaly, increasing of the size of the liver. And in prolonged congestion, parenchymal cells of the liver are replaced by connective tissue, and congestive cirrhosis develop. Right ventricular failure can cause the development of a core pulmonary, which means the hypertrophy of the right ventricle. Compensation mechanisms during heart failure. In heart failure, immediate or emergency and long-term compensatory mechanisms develop. Immediate compensatory mechanisms include heterometric, homometric, and chronoinotropic mechanisms, and long-term is hypertrophy of the myocardium. When the heart is overloaded with excess volume of blood, a heterometric mechanism compensation is activated. The significance of this mechanism is that when an excess amount of blood is delivered to the heart, the strength of the heart contraction increases. This is called Frank-Starling law. The expansion of the cavities of the heart, which means tonogenic dilatation, with excess blood overload is accompanied by an increase in stroke volume. At the same time, the heart is able to take an excess volume of blood and expel it to the periphery. In such cases, increasing of the systolic and diastolic volume is considered the main sign of the heterometric compensation mechanism. But when an end diastolic pressure rises excessively, at this time the heart myofibrils overstrain, lengthen. In this case, the Frank-Starling law is disrupted and the contractility of the heart weakens, and despite the increase in end diastolic pressure, the stroke volume begins to decrease. When the heart and its cavities overcome the resistance exerted by the expulsion of blood, the hemometric compensation mechanism is activated. At this time, the length of the fibers in comparison with width relatively little, and during the contraction occurs excessive resistance. To this, pressure rises in the cavities. At this time, heart expends a large force to push out the blood, and oxygen demand of the heart muscle increases. From an energetic point of view, the heterometric compensation is more advantageous than hemometric. In chronoinotropic mechanism is one of the urgent compensatory mechanisms which is activated when the heart function increases. The significance of this mechanism is that, according to an increase in the heart rate, the contractile strength of the heart increases too. The basis of the chronoinotropic mechanism is the acceleration of the entry of the calcium ions into the cardiomyocytes under action of the catecholamines. Myocardial hypertrophy is long-term compensatory mechanism that develop in the heart failure. Three stages of the myocardial hypertrophy are known: the emergency stage, relative stable hyperfunction and hypertrophy, and the third is decompensation stage. The emergency stage is characterized by an increase in the function of the cardiomyocytes. Increasing of the function of the cardiomyocytes activates energy production and protein synthesis here. An increase in myocardial mass in 30–70% gradually normalizes the work of the heart. The second stage, relatively stable hyperfunction and hypertrophy. At this stage, the supply of energy of the heart muscle, the synthesis of the nucleic acids and proteins meet their needs, and the heart mass increase in 100–120%, and dynamic parameters approach the normal levels, and hypertrophied cardiac muscle adapts to a new condition, and the state of complete compensation arises here. The third, progressive cardiosclerosis and decompensation stage. As the process takes long term, this leads to the weakening of the heart and the progression of the chronic heart failure. The development of dystrophic and sclerotic processes complicates in condition even more, and destroyed muscle fibers are replaced by connective tissue. Signs of the decompensation and total heart failure develops here. The vascular insufficiency may be acute and chronic. Shock, collapse, and syncope are accompanied by acute vascular insufficiency, and arterial hypotension is accompanied by chronic vascular insufficiency. The main link in the pathogenesis of vascular insufficiency is disruption of the correspondence between the capacity of vascular bed and the volume of circulating blood. As a result, venous pressure decreases and the volume of the blood flowing to the heart decreases. The heart pumps a small amount of the blood in the peripheral vessels, and oxygen supply of the tissue decreases. Coronary insufficiency. Coronary insufficiency means the inability of the coronary vessels to provide the heart with blood in an amount corresponding to its needs. Coronary failure may be relative and absolute. Relative coronary insufficiency develops during increasing of the heart work, for example, physical work, arterial hypertension. Moreover, even if here the coronary circulation accelerates, it cannot provide the growing needs of the myocardium. During absolute coronary insufficiency, the blood supply to the myocardium is disrupted, even at rest. The causes of the coronary insufficiency are, it may be the first is obturation, it is the blockage of the lumen of the coronary vessels, and it develops in the following reasons. The first is atherosclerotic plaque. It's the 90% of the cause of the myocardial ischemia. Coronary artery thrombosis mainly arises as a result of the atherosclerosis. Then coronary embolism, inflammation of the coronary vessels. All they are lead to the obturation of the lumen of the coronary vessels. The second is the angiospasm. Angiospasm is a spasm of coronary vessels that occurs as a result of the action of some substances, for example, catecholamines, vasopressin, angiotensin II, thromboxane A2, endothelin, even hypocapnia may lead to the spasm of the coronary vessels. And it was compression occurs as a result of compression of the coronary vessels from the outside by scar, by tumor tissue, and this condition can also occur in tachycardia, because during systole, increasing accelerated systole, the duration of the compression of the coronary vessels increase. Coronary heart diseases or ischemic heart diseases. These include pathologies that develop as a result of coronary insufficiency and are accompanied by various injuries in the myocardium. The forms of the coronary heart diseases are angina pectoris, the pre-infarction state, myocardium infarction, and cardiosclerosis. Angina pectoris occurs as a short-term acute coronary insufficiency, 20 minutes. And manifests the main manifestation of the pain accompanied by a sense of the fear and vegetative reactions. The pre-infection state, or is called intermediate coronary syndrome. This develops with a duration of the myocardial ischemia of the 20 up to 40 minutes. And myocardial infarction is the necrosis of the heart muscle as a result of the impaired coronary circulation. Cardiosclerosis is a sclerotic change in the heart muscle, and it may be diffuse, for example, which is called atherosclerotic cardiosclerosis, and focal, which is called post-infarction, after infarction cardiosclerosis. Etiological factors of coronary heart disease include atherosclerosis, spasm, thrombosis, coronary embolism. And there are some risk factors that create the condition for the development of these etiological factors. The risk factors are the hypercholesterolemia, the obesity, arterial hypertension, diabetes mellitus, physical inactivity or a hypoadynamic lifestyle, bad habits, and etc. Angina pectoris is a typical form of coronary insufficiency, which is manifested by pain. Pain often occurs during negative emotions, physical exertion, sometimes during eating. The forms of the angina pectoris are the stable angina pectoris, then presmetal angina, and non-stable angina pectoris. The stable angina pectoris is the most common and associated mainly with the spasm of the atherosclerotic coronary vessels during physical and emotional overstrain. Such vessel at rest satisfies the myocardial blood needs. However, in physical and emotional overstrain, this need is not satisfied and relatively coronary insufficiency occurs. Presmetal angina pectoris is associated with prolonged spasm of the coronary vessels. Spasm occurs in the coronary arteries with minor stenosis or change, and mostly an attack of pain occurs at rest, especially during sleep. It's assumed that this is associated with an increase in the tonicity of the vagus nerve. Unstable angina pectoris occurs with a more severe atherosclerotic damage in the wall of the coronary vessels. This type of angina pectoris is characterized by severe pain attacks, even at rest. Attacks of pain are long and the coronary lytics non-effective here, and often this leads to the myocardial infarction. Characteristic signs of the myocardial ischemia are noted on the ECG are the negative T wave and the depression of the ST segment. Myocardial infarction is a necrosis in a certain part of the heart muscle that develops as a result of cessation or acute decrease in blood circulation in this area. Myocardial infarction is a typical form of acute coronary insufficiency, and this develops as a result of the cessation of the supply of myocardium with oxygen and nutrients. Among the causes of myocardial infarction, coronary atherosclerosis play an important role. Atherosclerotic plaque narrows the lumen of the artery, and heart muscle is not provided with sufficient blood. And favorable conditions for thrombosis are created in atherosclerotic vessels. Atherosclerotic plaque breaking away from the place of formation can completely block the luminal vessels, cause embolism. Thus, thrombosis, embolism, and prolonged spasm of the coronary vessels play a crucial role in the etiology of the myocardial infarction. Resorption necrotic syndrome develops as a result of absorption of the products of necrotic tissue during myocardial infarction. This syndrome is manifested by a number of signs. For example, fever, leukocytosis, increasing of the erythrocyte sedimentation rate, ECR, and increasing of the concentration of some enzymes in the blood. For example, creatine phosphokinase, AST transaminases, and because of the from damaged cardiomyocytes, these enzymes enter to the blood and their concentration increase in the blood. Then hypermyoglobinemia, the identification of the specific proteins of the cardiomyocytes, cardiac troponin, TI syndrome. All they are the main manifestations of the resorption necrotic syndrome. And even Dressler syndrome may develop during the myocardial infarction. It's an autoimmune response against the altered myocardial proteins. This Dressler syndrome is occupied by the pericarditis, pleurisy, and pneumonitis. In myocardial infarction, three zones are distinguished in the area of damage. Necrosis prevails in the central part, and it's surrounded by the area called the zone of lesion and the zone of ischemia between the zone of lesion and the healthy tissue. Depending on the localization of the focus of the necrosis, myocardial infarction can be subendocardial under endocardium, subepicardial under the epicardium, and intramural in the middle part of the heart muscle, and transmural, where damaging the wall of the heart in the transverse direction. The ECG change in the myocardial infarction depend on the localization of the lesion and necrotic processes, and the depth of the damaged area, and the stage of development of diseases, and other factors. The main ECG marker of the myocardial ischemia is a negative T wave. For myocardial lesion is the elevation of the ST segment. And the occurrence of the necrosis in the myocardium is accompanied by ECG, on the ECG by deepening of the Q wave and decreasing of the amplitude of the R wave. As the necrosis zone increases, the Q wave deepens more and more, and the R wave shortens or completely disappear. And here the QS complex may form. Complications of myocardial infarction can be divided in two groups, early and late complications. Early complications can occur in days, hours, even minutes, and these include cardiogenic shock, acute heart failure, acute aneurysm, or cardiac tamponade, thromboembolism, and etc. The late complications include Dressler syndrome, chronic heart aneurysm, chronic heart failure, etc. And the development of the cardiogenic shock is associated with an acute weakening of the pumping function, contractibility of the heart. And cardiogenic shock is the most dangerous complication of the myocardial infarction, leading to the death in 80% of the cases. Dressler syndrome is autoimmune damage to the heart, and it proves that against denaturated proteins, the passage from the damaged cardiomyocyte to the blood flow, the antibodies or sensibilized lymphocytes are formed in the body. Cardiosclerosis is a pathological condition characterized by the formation of the scar tissue at the site of dead cardiomyocytes. Because the scar formed here, tissue is not involved in heart contraction, and the load on cardiomyocytes increases. The clinical manifestation of the cardiosclerosis depends on the size of the scar tissue developing in the myocardium. So, if the scar tissue occupies a large area, then the clinical signs of the heart failure are more pronounced. The cause of the cardiosclerosis include myocardial infarction, atherosclerosis, myocarditis, various myocardial dystrophy, and etc. The types of cardiosclerosis are atherosclerotic cardiosclerosis, cardiosclerosis that occur after heart attack, after myocardial infarction, and atherosclerosis, cardiosclerosis after myocarditis. Atherosclerotic cardiosclerosis developed as a result of atherosclerotic change in the coronary vessels for many years. Due to the fact that the muscle tissue in the heart is constantly experiencing oxygen starvation, is gradually being replaced by connective tissue. Connective tissue is evenly distributed the myocardium and is diffuse. And for many years, the patient may not show any complaints. Over time, signs of the heart failure appear, and atherosclerotic cardiosclerosis is more common for all ages. Post-infarction cardiosclerosis develops at the site of necrosis after myocardial infarction. Repeated heart attacks lead to the formation of the scar tissue in various areas of the heart and a decrease in the contractility of the heart. Because scar tissue develops in various areas of the necrotic myocardium, it's focal. And the cardiosclerosis after myocarditis develops as after the myocarditis of various origin, and this type is common for adults, adolescents, and children. Arrhythmias are the abnormal heart rhythm and are typical form of the cardiac pathology. And development of arrhythmias are associated with a disturbance of the automaticity of the heart, its excitability, conduction, and contractility. Therefore, the forms of the arrhythmias are: the first is arrhythmia associated with impaired heart automaticity. The second is the arrhythmias associated with the impaired excitability. Then arrhythmias associated with impaired conduction of the heart in the heart muscle, and arrhythmias associated with the simultaneous disturbance of the excitability and conduction of the heart. And at last, the arrhythmias associated with the impaired contractility of the heart. Arrhythmia associated with a change in the automaticity are divided in two groups: homotopic rhythms and heterotopic rhythms. In homotopic arrhythmia, the pulse source is the sinus node, and in heterotopic, the pulse source is located in the lower parts of the conduction system. Homotopic rhythms include the sinus tachycardia, sinus bradycardia, sinus or respiratory the arrhythmia, and weakness of the sinus node, tachycardia bradycardia syndrome. In sinus tachycardia, the heart rate exceeds 90 beats per minute, but all other indices of the ECG are normal. The reasons are increased sympathoadrenal effects on the heart, or weakening of the parasympathetic effects on the heart. In sinus bradycardia, the number of heartbeats is less than 60, and the reasons are the increasing of the tonicity of parasympathetic nerve system. The parasympathetic effect on the heart increase. This condition is observed in irritation of the nuclei or the receptors of the vagus nerve. For example, increased intracranial pressure due to meningitis, encephalitis, and other pathologies, and increase in intraventricular pressure, or the weakening of the sympathoadrenal effect on the heart may lead to the formation of the sinus bradycardia. And sinus arrhythmia means a change in the heart rate depending on the phase of the respiratory act. Thus, the acceleration of the heartbeats during inspiration and deceleration, decreasing of the heartbeats during expiration. In this case, the heart rhythm is manifested by alternation of the tachycardia and bradycardia, as you see in the slide. And plus the weakness of the sinus node. Tachycardia bradycardia syndrome is explained by disturbance of the automaticity of the sinus node and the formation of the heterotopic foci. Unlike sinus arrhythmia, in tachycardia bradycardia syndrome, a change in heart rate doesn't depend on the phase of the respiratory act. The development of the heterotopic rhythms is due to the fact that as a result of the weakness of sinus node or the cessation of its activity, pacemaker is transferred to the center of the automatism of the second and third order. The types of the heterotopic rhythms are the following: slow atrial rhythm. In this case, the pacemaker is located in the pathway of the left atrium, and heart rate is less than the 70 beats per minute. And slow atrial rhythm is observed during neurosis, congenital and acquired heart defects, cardiomyopathies, and other. Atrioventricular AV node rhythm, and this is observed when the pacemaker is located in upper, middle, or lower parts of the AV node. At the same time, the heart rate decreases from 70 to 40 beats per minute. The higher the source of the pulse, the greater the heart rate. And arrhythmia associated with impaired excitability of the heart. This type of arrhythmia are associated with the ectopic foci, which are cause of an extraordinary contraction of the heart. It's known that, unlike the cardiac conduction system, cardiomyocytes don't possess the property of automaticity. In the development of the pathologies in the myocardium, these cells can acquire the ability of the automaticity, spontaneous depolarization. If in such cardiomyocytes the rate of the spontaneous depolarization exceeds the rate of the pulse generation in the sinus node, then they turn into ectopic foci. In pathologic states, for example, in myocardial infarction, Addison disease, and etc., spontaneous depolarization in cardiomyocytes is associated with a change in the concentration of the ions, especially potassium ions, in the extracellular and intracellular spaces. So in cells that don't have the automaticity reaching the membrane resting potential of the 60 millivolt as in the sinus node, these lead to the appearance of the spontaneous depolarization in them. And arrhythmias associated with impaired excitability in the heart muscle include extrasystole and premature contraction and the paroxysmal tachycardia. Extrasystole is an extraordinary contraction of the heart or the certain part of the heart. According to the localization of the ectopic focus, which is cause the extraordinary cardiac contraction, maybe sinus, the extrasystole, atrial, atrioventricular, ventricular, extrasystoles. In atrial extrasystole, an extraordinary impulse occurs in the wall of the atria, and on the ECG, a low voltage P wave arises prematurely. If the pulse arises in the region close to the AV node, the excitation wave propagates in the opposite direction and the P wave becomes negative. In AV atrioventricular extrasystole, the source of the additional impulse is located in the AV node, and an excitation wave originating from the upper and middle parts of this node propagates in two directions. It is normal in the ventricles and retrograde in the atria. Moreover, on the ECG, after the normal complex of the QRS, the negative P wave is noted. The duration of the diastole after the extrasystole is long. Extrasystole may be accompanied by a simultaneous contraction of both the atria and ventricles. Ventricular extrasystole is characterized by compensatory pause after an extraordinary contraction of the cardiac contraction. This is due to the fact that the next normal stimulus of the excitation leaving the sinus node enters the refractory phase of the ventricles. After the ventricles exit the refractory phase, a new wave of impulses that arise in the sinus node provides another ventricular contraction. Due to the propagation of the excitation wave in the anterograde and retrograde directions in the ventricular extrasystoles, an altered QRS complex attacks attention. Paroxysmal tachycardia is a sudden paroxysmal occurrence in the ectopic foci of the high-frequency impulses. Moreover, the number of the ectopic foci is more than 3-5, and the number of arising impulses varies between 160 to 120 in a minute. In paroxysmal tachycardia, often repeated group extrasystoles disturbs the pathological physiological rhythm of the heart, and tachycardia attacks can last from a few seconds to several minutes, then suddenly stop and the normal heart rhythm is restored. Otherwise, it can be complicated by atrial fibrillation. Arrhythmia associated with the impaired conduction of the heart can be manifested by blockade in the transmission of the impulses or an acceleration of their conduction. And in blockades, the transmission of impulses along the conductive system slows down or completely stops. The main reasons for the development of the heart block are associated with functional or organic changes in the conductive system. And blockage of the impulse may be between the sinus node and the atrium, inside the atria, in the AV node, or in the bundle of the His and its legs inside the ventricles. And from this point of view, the following types of the blockade are distinguished. sinoauricular blockade, intraatrial, atrioventricular, and intraventricular blockades. All types of the blockades can be partial and complete. And there are some types of the arrhythmia where the conductivity of the impulses accelerate. For example, this type of arrhythmia include WP double syndrome, Wolff-Parkinson-White syndrome, or the Clerc-Levi-Krisenko syndrome. In atrioventricular or transverse blockade, impulse transmission from the atrioventricular node to the ventricles is impaired, and there are partial or complete transverse blockade. 3 degrees of these blockades are distinguished. Transverse blockade of first degree. This is associated with the slowdown in the conduction of impulses from the AV node. And on the ECG, the PQ segment, PQ interval, lengthen. Normally it's a 0.12, 0.20 seconds. Transverse block, the first degree, does not cause noticeable hemodynamic disturbances. And there are 2 types of the transverse blockade of the second degree, Mobitz 1 and Mobitz 2. In Mobitz 1, the progressive prolongation of the PQ interval on the ECG is observed until the one ventricle complex, QRA complex, falls out. And then the duration of the PQ interval returns to the normal and gradually begins to prolongation again. And this process is cyclic character. That's why this is called the Wenckebach periods. The occurrence of the Wenckebach-Samueller periods is associated by the relative and the absolute refractory period in the AV node. During the absolute refractory period, the atrioventricular node is not able to transmit an impulse from the atria to the ventricle, so another ventricular contraction occurs. Usually such a pause repeats after the 5-7 heartbeats. During this time, the excitability of an AV node is restored and cycle repeats. In Mobitz 2, in the second degree of the atrioventricular block, until the QRS complex fall out, but progressive lengthening of the PQ interval is not observed. Sometimes in Mobitz 2, 2 or more ventricular complexes may fall out. This is considered a more severe form of conduction disturbances, which is observed in the transmural myocardial infarction or chronic degenerative damage to the conduction system of the heart. In third degree of the AV block, it is called complete transverse block of the heart. The transmission of the impulses from the atria to the ventricle is completely stopped. And in other words, the mismatch occurs between contraction of the atria and ventricles. The atria contract at their sinus rhythm, 70 contractions per minute, and the ventricles at a idioventricular rhythm, the AV rhythm, nodular rhythm, the 25-35 contractions per minute. And in complete blockade on the ECG, the number of the P wave relatively exceeds the number of QRS complex. In the transition of the atrioventricular block to the second degree to a complete transverse block as a result of complete cessation of the impulse from the atria to the ventricle, ventricular asystole is observed for a certain time. Moreover, due to the fact that a very small amount of the blood flows to the brain, the patient loses consciousness and epileptic seizures are observed, spasm observed. Convulsions occur in this condition. This condition is considered the most dangerous complication of the complete heart block and is called the Morgan-Eden-Stokes syndrome. Acceleration of the conduction in the heart occurs during the transmission of the impulses arising in the sinus node along the main atrioventricular and additional which include pathological changes which occur in the pathological change in the heart, with the additional pathways to the ventricles. In this case, impulses transmitted through the additional conduction pathways reach the ventricle faster than impulses arriving at the ventricle along the atrioventricular pathway. Thus, additionally propagating impulses lead to the premature excitation of a certain part of the ventricles, and the impulses from the atrioventricular node excite the ventricles relatively late. All these lead to the tachycardia during, for example, Wolff-Parkinson-White syndrome, WPW syndrome. And this syndrome manifests itself in the form of the paroxysmal tachycardia, atrial fibrillation, or flutter. This syndrome is also called ventricular premature excitation syndrome. In WPW syndrome, excitation is transmitted to the ventricle along the main atrioventricular pathway and additional pathway, which called Kent pathway, Kent bundle, and ventricular tachyarrhythmia occurs. Normally, the excitation wave propagates from the sinus node to the atria, reaches the AV node, and here the propagation of impulses slows down. This is called physiological inhibition of the impulses. Therefore, the ventricles contract with a little delay after the atria. And in the patients with WPW syndrome, impulses coming through the additional pathway located outside the atrioventricular node immediately reach the ventricles and excites them. In this syndrome, the atria and ventricles contract simultaneously. This leads to the disruption of the hemodynamics and a decrease in the efficiency of pumping function of the heart. The change characteristic for this syndrome, for the WPW syndrome on the ECG, include the shortening of the PQ interval on the background of the sinus rhythm, the expansion of the QRS complex, and the formation of the delta wave on the ascending part of the R wave. It is called the formation of the delta wave. Arrhythmias associated with the simultaneous disruption of the excitability and conduction of the heart. These types of arrhythmia include atrial flutter, where the pulse rate per minute is 2/400. Atrial fibrillation, the heart rate is the 4/6 the contractions per minute. Ventricular flutter, pulse frequency is 150 300 per minute, and ventricular fibrillation, the pulse frequency is 500 per minute. During the functioning of the many ectopic foci in the heart, the propagation of the impulses in the myocardium is disturbed, or the propagation of the impulses in different multiply directions leads to the fact that the excitation wave circulates for a long time in the heart. As a result, a rhythm disturbance develops in the heart. The atrial fibrillation may develop by this way. In atrial flutter, the number of pulses in a minute reaches 200-400, as a result of which one part of these impulses is blocked in the AV node and cannot pass the ventricle. Thus, the ventricles respond only the second or fourth atrial contraction. The rest of the excitation waves fall into the refractory phase, because the AV node cannot transmit more than 200-220 impulses per minute. In atrial flutter, on the ECGs, the P wave disappears and low amplitude frequent F waves appear in its place. QRS complexes are normal. If the number of impulses arising in the atria reaches 4/6 per minute, then there is a atrial fibrillation occur. In ventricular flutter, on the ECG, irregular waves with a frequency of the 150-300 per minute are noted. In this case, the QRS complex is sharply deformed. It is often impossible to distinguish between the ST segment and the T wave. Ventricular fibrillation is a chaotic, irregular contraction of the individual muscle fibers or their individual groups as a result of asynchronous excitation, not synchronous excitation occur here. This can lead to the cardiac arrest and cessation of the blood circulation. This is a very dangerous type of arrhythmia, which if the emergency measures are not provided, this can lead to the death within 3-5 minutes. Ventricular fibrillation can develop as a result of a number of pathogenic effects. For example, the passage of electric current through the heart, in some types of anesthesia, chloroform anesthesia, for example, and blockade of the coronary vessels, the toxic effects of digitalis and calcium preparations. On the ECG waves of a low amplitude, the various shapes with a frequency of 300-600 per minute are noted on the QRS complexes, and they are even more deformed. The amplitude of the air waves, R waves, gradually decreases, and sometimes they cannot drop out. There is a sudden cardiac arrest and asystole occur. The most effective treatment for ventricular fibrillation is ventricular defibrillation or electroshock, when using a specific device, the machine, the defibrillator. For a short time, 0.1-0.2 seconds, a high voltage current is passed through the heart. And the value of this method is force the heart to contract synchronously. One of the theories explaining the development of fibrillation is a re-entry mechanism. According to this mechanism, an excitation wave propagates in the myocardium in various directions. There are some conditions under which the re-entry mechanism may develop. The first, an impulse that passes from the one point of the myocardium obtains the ability to pass through two or more waves. For example, the formation of the additional pathological waves in Wolff-Parkinson-White, WPW syndrome. Also, it occurs in extrasystole, in ectopic foci, in fibrillation arrhythmias. And second is when the conductivity of these waves are differ from each other. For example, in WPW syndrome, conductivity by Kent wave faster than by AV node. And in fibrillation, different ectopic foci have different conductivity. And at last, these mentioned conditions lead to the formation of the different refractory periods in the myocardium. In normal condition, for acceptance and propagation of the newly formed impulses in normal state, all fibers of the heart muscle must simultaneously exit from the refractory period. In pathological process, in some area of the myocardium, the refractory period in this area can be extended. As a result of this, the passage of the impulses through this region of the myocardium in the anterograde normal direction is blocked, and a wave of the impulses propagating from an unblocked region in the retrograde direction upon reaching an area with a pathological. In this process, this region emerges from the refractory period, and the wave of impulses passing from here enters a new cardiac circle. Thus, in myocardium, there is a repeated continuous circulating of the excitation waves propagating in the retrograde direction. In fibrillation, due to the appearance of the numerous ectopic foci in the myocardium, the occurrence and duration of the refractory periods of the various muscle fibers differ from each other. As a result, there is no synchronous contraction and myocardial relaxation in general. This causes the development of fibrillation by a re-entry mechanism. Atherosclerosis is a chronic disease which is accompanied by the deposition of the lipids and proteins in the intima of the arteries and the development of elements of the connective tissue here. In this slide, you see the stage of the development of the atherosclerosis. The first is endothelial damage and dysfunction, then accumulation of the proteins in the intima of the blood vessels. The next is adhesion of the monocytes, platelets to the endothelium and their migration to the intima. Then the synthesis of the growth factors, migration to intima, and proliferation of the smooth muscle cells. And plus the extracellular matrix synthesis and the formation of the atherosclerotic plaque. The first stage of the pathogenesis of the atherosclerosis is the chronic damage to the endothelial vascular endothelium. The factors leading to the damage to the vascular endothelium include hyperlipidemia, hemodynamic disturbances, for example, hypertension diseases, and the bad habits, nicotinism, smoking, for example, some toxins, viruses, immune complexes, all they may damage the endothelial cells of the vascular wall. Endothelium damage leads to the increasing of its thrombogenic property, permeability, and adhesive ability. The adhesion of the monocyte to the endothelium and migration of the intima are accelerated. Monocytes having absorbed low-density lipoproteins in a non-specific way turn into foam cells or scavenger cells. Foam cells saturated with lipids, then they destroyed, and the cholesterol passes into the intercellular space. Here they again activate the macrophages and the process repeats. Foam cells concentrated in the damaged part of the intima, and platelets synthesize growth factors. These factors stimulate the migration of the vascular smooth muscle cells into the intima and their proliferation. Due to the action of the growth factors released from the activated cells, the synthesis of collagen and proteoglycans are stimulated, and the extracellular matrix is formed. Thus, an atherosclerotic plaque, or another name of this plaque, atheroma, is formed. According to the etiopathogenesis, the following types of atherosclerosis are distinguished. Atherosclerosis, or this called metabolic arteriosclerosis, arteriosclerosis or hyalinosis, inflammatory, toxic, allergic. Other types of arteriosclerosis are known, and one of the forms of the arteriosclerosis is the Minkeberg arteriosclerosis, and this type, Minkeberg arteriosclerosis, is characterized by damage in the medial layer of the walls artery, and in this case, media necrosis, media calcinosis, and mediosclerosis develop. The level of blood pressure in the body depends on the minute volume of the heart, peripheral vascular resistance, elasticity of aorta, large vessels, and the volume of circulating blood, and also rheological properties of the blood. Change of arterial pressure may also be associated with impaired regulatory mechanisms that maintain a stable level of blood pressure. The main indicator of vascular tone is systolic blood pressure. The level of the systolic blood pressure depends on the stroke volume of the left ventricle, the rate of maximum expulsion of the blood, and aortic tone. Normally, systolic pressure is 100–140 mercury, and the level of the diastolic blood pressure depends on the tone of the arterioles, blood volume, and a certain extent of the fraction of the expulsion of the heart. Normally, diastolic blood pressure is 60–90 mercury. The differences between systolic and diastolic blood pressure is called pulse pressure. An increase in blood pressure is associated with a disturbance of the interrelation between pressor and depressor factors in the body. The pressor effect is provided by sympathoadrenal system, renin-angiotensin system, aldosterone vasopressin system, glucocorticoids, also thromboxane A2, endothelin, and others. They are the factors which increase the blood pressure. And the following are depressor factors, for example, prostaglandin A, E, prostacyclin E2, the kinin system, then also the natrium uretic hormone of the atria, and the relaxation factor, the nitric oxide. Arterial hypertension is prolonged and persistent increase in blood pressure. Approximately 40% of cardiovascular pathologies associated with the arterial hypertension. Arterial hypertension is primary and secondary. Primary hypertension is not linked with the pathology of the various organs and systems. This type of hypertension is also called essential hypertension or hypertension disease. Secondary arterial hypertension develops in pathologies with various organs and systems and called symptomatic arterial hypertension. The pathogenesis of the hypertension is based on dysregulation and membrane concepts. According to the concept of dysregulation, the development of the hypertension is associated with impaired regulatory mechanisms of the blood pressure. So, firstly, permanent emotional overstrain or in the central nervous system format, a pathological dominant focus occur here, and the sympathetic adrenal system is activated. Catecholamines are secreted into the blood. The cardiac output increases and the total peripheral vascular resistance increases. The spasm of the renal vessels lead to the increased synthesis and secretion of the renin. The renin-angiotensin-aldosterone system is activated. Aldosterone secretion leads to the hypernatremia and an increase in the osmotic pressure of the plasma. Irritation of the osmoreceptors activates the secretion of the vasopressin, antidiuretic hormone. Vasopressin causes excess reabsorption of water in the kidneys and water retention in the body and increase in the circulated blood volume. As a result, there is an increase in cardiac output and the increase in the blood pressure. Then the next next phase, irreversible structural change occur in the wall of the resistive vessels. This phase is also developed with a certain sequence. Hyperfunction of the smooth muscle of the vascular wall is associated with a frequently recurring spasm, and hypertrophy of smooth muscle in the wall of the arterioles develop. After a long period of the time, this turns into dystrophic change and the death of the smooth muscle cells, the development of connective tissue elements on their place, and the atherosclerosis is formed. Arterioles turn into the tube-like form and that have lost elasticity. Perfusion of the vital organs as brain, heart, liver, kidney are disrupted. In some cases, there is a rupture of the such arterioles and hemorrhage in the brain. The hemorrhagic stroke may occur. Arterial hypotension, prolonged decrease in blood pressure, less than 100 to 60 millimeter mercury. It's more common in the people with asthenic constitution. This state may be manifested by general adynemia, fatigue, dyspnea, dizziness, and headache. Arterial hypotension is acute and chronic. Acute hypotension develops in acute vascular insufficiency, for example, shock, polyps, syncope. Chronic arterial hypotension is divided in two groups, primary and secondary. The development of the arterial hypotension is associated with weakening of the contractile function of the heart, decreasing of the circulated blood volume, and decreasing of the tonicity of the peripheral vessels. Moreover, arterial hypertension is divided into neurogenic, endocrine, and metabolic types according to their origin. Thank you for attention.